a later date. It is my pleasure to introduce our President and CEO, Mary McGowan.
Thank you, Kate, and hello all. On behalf of the Foundation for Sarcoidosis Research, it is my pleasure to welcome you to today's webinar, which will focus on a topic that is complex and under-discussed: rare manifestations in sarcoidosis. Less common manifestations can be difficult to diagnose and even more challenging to manage, but understanding them is essential to advancing treatment and improving quality of life for those affected. And I am thrilled to see such an incredible turnout for today's webinar. More than 1,100 people registered for this webinar, the highest number we have ever had for one of our educational programs at FSR. I think this really underscores the importance of this topic and our community's desire to need to learn more about this disease, but also that Dr. Ribeiro is a world-renowned expert in sarcoidosis diagnosis, treatment, and care, and we are honored to have him join us this afternoon. The FSR team is here to support you, to connect you with others in the community, to help you learn more about living with sarcoidosis, to bring opportunities for you to become engaged in our efforts and to raise awareness, provide education about sarcoidosis and related topics, support each other, advocate, and advance sarcoidosis research. The information presented in today's program is intended for educational purposes. It should not be considered medical advice. We always encourage individuals to speak with their own healthcare providers about any questions or decisions related to their care. I also want to take a moment and thank our generous sponsors: Walgreens, Mallinckrodt Pharmaceuticals, A&I Pharmaceuticals, and aTyr. It is now my pleasure to introduce today's presenter from the Cleveland Clinic, one of the founding members of the FSR Global Sarcoidosis Clinic Alliance, launched just 3 years ago and has expanded to nearly 50 members. Dr. Manuel Ribeiro earned his MD degree in Brazil at the Federal University of Bahia in 2006. He completed residency in internal medicine at Jackson Memorial Hospital, University of Miami. In 2010, he was elected into the Alpha Omega Alpha Honor Medical Society. Dr. Ribeiro completed 3 years of pulmonary and critical care fellowship training at the Cleveland Clinic. After completion of his fellowship training in 2013, Dr. Ribeiro returned to Brazil, where he served as coordinator, respiratory medicine service at Hospital Cardiopulmonar in Salvador. He rejoined the Cleveland Clinic in 2016. Please join me in welcoming Dr. Ribeiro.
Mary, thank you very much for the kind introduction, kind words. Thank you, Kate, and everybody from FSR for the invite. It's a huge honor to be here. And I guess the first thing that I have to do is to try to get this technology right. So let me see if I can share my screen here. And can you all see my screen? At least maybe one okay there from you?
Yes, we can see it. Thank you.
Perfect, perfect. Thank you. Thank you again, Mary and Kate. So huge pleasure to talk to all of you today. And as I was getting this presentation ready on rare manifestations of sarcoidosis, I really went back to many things that I heard from all of you patients, over this past many years. And this is one of them, right? We've all heard this before. We've all said this before. Sarcoidosis is no flake disease, which means that no two patients are the same. So imagine how many patients are walking out there with different, rare, unusual manifestations of sarcoidosis. It shows the importance of this topic. The other thing that I hear from you all the time is, if something is rare, it will happen to me. So my goal on this talk was really to be as broad as possible and try to tackle as many rare manifestations as possible. So whenever you are listening to this, you can at least find 1, 2, or 3 things useful to you or to somebody you know. This is what we'll talk about today. So first, is sarcoidosis a rare disease? Are we still talking about a rare manifestation of a rare disease? Then why do rare manifestations happen in sarcoidosis? Then we'll talk a little bit about definition of a rare manifestation, and then we'll move to the main part of the talk, which are really, actually the rare manifestations. I decided to divide this in two groups. One, rare manifestations happening in common organ involvement, such as pulmonary sarcoidosis, for example. So we'll tackle a few rare manifestations of pulmonary sarcoidosis. And then we'll go to the part of the talk talking about rare manifestations in organs that are very unusual to see in sarcoidosis, such as the gastrointestinal tract. So we'll talk about that as well. Um, so first thing, is sarcoidosis still a rare disease? And the answer to that is yes. So the Orphan Drug Act from 1983, this was a law designed to help the development of drugs for orphan or rare diseases. And they define rare disease in the US as diseases affecting less than 200,000 people in the US, with some exceptions for diseases affecting more than 200,000 people. But at least based on the last large US study looking at the prevalence of sarcoidosis here in the US, the prevalence of sarcoidosis at that time in 2013 was 60 cases per 100,000. Applying that to the US population at that time, that was below the 200,000 cutoff. It's probably a little bit higher right now, but it is still officially considered a rare disease. If we look at the FDA database, you can see that up to this day, medications are being given this orphan drug status for sarcoidosis. So yes, we are still talking about rare manifestation of a rare disease, which sarcoidosis is. So moving on to another important issue, why do rare manifestations happen in sarcoidosis? And I think it goes back to the granuloma, right? You've all heard about granulomas, of course. You've all seen pictures of granulomas. So this is just one of them. And if you focus here on the right side of the graph of the picture, you see that the granulomas are formed after a series of important cytokines and cells, and cytokines such as interferon gamma and TNF alpha, after they cause the formation of the granuloma and the multiplication of the granuloma. And here's the thing, this granuloma can affect any organ, right? So virtually any organ can be affected by this granulomatous inflammation. So you can see patients walking with pulmonary sarcoidosis, cardiac sarcoidosis, cutaneous sarcoidosis. There is already a lot of variability in the disease manifestation just based on where this granulomatous inflammation can happen. But if you focus on the left side of the picture here, you'll see other important things that explain why rare manifestations happen. So if you focus on this part here, you'll see that we still believe that sarcoidosis is caused by environmental exposures, right? There are a lot of potential culprits being studied as potential triggers, potential causes for sarcoidosis. And there are really a lot of them. So specific type of infections from mycobacteria, from different bacteria, smoke inhalation like firefighters have, for example, pesticides, musty odors, moldy environments, a lot of different potential manifestations, potential exposures being linked to sarcoidosis. And whenever a patient is exposed to one of those things, the cells present those antigens to the lymphocytes through this HLA molecule. This is a protein on the surface of a few cells that present those antigens to the lymphocytes. And guess what? The genes that encode those HLA proteins, they also vary a lot. There are a lot of different types of HLA genes or subtypes. And if you start to put together all of those different types of exposures or possible exposures, and then different types of HLA molecules, you see a lot of combinations, a lot of potential different manifestations. And a few studies showed this already. This is just one of them. This is the AXIS study, a very large study here from the US with more than 900 patients in this case, that showed that patients with this specific HLA genotype, the DRB1-1101, if they were exposed to pesticides, they were more likely to have cardiac sarcoidosis or hypercalcemia. But if patients with the same genotype were exposed to musty odors, they were more likely to have pulmonary involvement only. So again, I think this gene environmental interactions, they at least partially explain why we see a lot of rare manifestations in sarcoidosis. So let's define those rare manifestations because we'll spend the next 30 minutes talking about all of them. So it's better to start with a definition. As I mentioned to you, I will start by talking about rare manifestations from common organ involvement. For example, rare manifestations of pulmonary sarcoidosis. There's no really established definition in the literature defining rare manifestations of those common organ involvements. So I made it easy to me. I went with the dictionary definition of rare, which is basically manifestations not occurring very often. So anything that I've seen or that I found in the literature that I thought was useful, not occurring very often, I'll share with you today. Then the last part of the lecture will be to really tackling those organs that are rarely involved, such as, for example, the gastrointestinal tract. For that, we do have established definition. Dr. Judson and his group a few years ago published a study looking at those rare organ involvements, and he defined rare sarcoidosis organ as one that was not specifically addressed in the WASOG organ assessment instrument. So let's take a look at this WASOG instrument. We use this quite a bit to help with the diagnosis of sarcoidosis. And you can see all of the organs that were included in that WASOG instrument: lungs, skin, liver, eye, spleen, salivary gland, you name it. A lot of important organs being included in that. So first, we'll start talking about some rare manifestations in those organs, and then we'll move to organs that were not even included in that publication, and those are really the rare organ manifestations that Dr. Judson described. Starting with pulmonary, right? So the most common manifestation of sarcoidosis, but yes, there are rare manifestations of pulmonary sarcoidosis. This is one of them, cystic lung diseases. If you look at those pictures here, those basically black holes here in the lungs, those are called cysts. This is very unusual in sarcoidosis. We rarely see this. And this is one study from France showing how rare this is. They found only 12 patients in their groups in France and Italy, actually, from 2007 to 2023 with this presentation of cystic lung disease. 12 patients out of 732. So this is 1.6% of patients with sarcoidosis presenting with cystic lung diseases. Thankfully, the prognosis of those patients in that study was as good as patients with other more common manifestations of pulmonary sarcoidosis. So treatment, for example, will be the same. Another very rare one, and this is still very controversial. I even debated if I should include this in the lecture or not, but I think it's important, so I decided to include it. This is called usual interstitial pneumonia. It's a specific type of scar tissue that we see in the lungs, mainly in another type of lung disease called IPF, or idiopathic pulmonary fibrosis. This is not usual in sarcoidosis at all. We rarely see this. In fact, there's still debate if this is really caused by sarcoidosis or just a coincidence. This is just one study done here in the US, favoring that maybe it's a little bit more than just coincidence. They included 25 patients from the US with sarcoidosis and this UIP pattern. And by the way, if you look at this picture here on the right, you can see scar tissue both on the top and the bottom of the lungs. As you know, sarcoidosis most commonly affects the top of the lungs. So again, when we see all of this scar tissue here in the bottom of the lungs, this is unusual for sarcoidosis. And when we specifically see some of those characteristics here, this is consistent with this UIP pattern. But this study found 25 patients with both sarcoidosis and this UIP pattern affecting mainly the bottom part of the lung. 3 of those patients, I think, were the most convincing ones because they had the diagnosis of sarcoidosis and UIP around the same time with lung biopsy showing UIP and sarcoidosis. So again, just one study, very small, but probably suggesting that there's a little bit more than just coincidence there. Some patients, I think, may have really sarcoidosis causing this UIP pattern, but again, extremely rare. The importance of that is this pattern, unfortunately, tends to get worse faster than other forms of sarcoidosis or even other forms of lung diseases. So we have to be aware of that and monitor patients closely. This is probably a more famous one. You may have heard of this before, necrotizing sarcoid granulomatosis, or NSG. This is also rare. It's a type of sarcoidosis that causes mainly inflammation of the vessels and then also necrosis, dead cells in the lung tissue. But very, very important, to make a diagnosis of NSG, you have to have a biopsy showing those things, but on a background of classic sarcoidosis, classic non-necrotizing granuloma. So you have to have those two things. Again, thankfully, the prognosis is similar to other forms of pulmonary sarcoidosis, so treatment is pretty much the same. And here you see one case reported in this paper by Dr. Sharma many years ago with those white areas, those dense consolidations that usually we don't see in sarcoidosis, but we do see in patients with this NSG type. Here in the right, it's a biopsy showing a blood vessel here. You see the lumen of the blood vessel, and to the side of that blood vessel, some giant cells, some granulomas. So sarcoidosis affecting directly those blood vessels. This patient actually has another rare manifestation, which is this fluid here around the lung. This is called pleural effusion. So this is the next one that we'll talk about. This is rare. This was shown by Dr. Judson in one of his studies, taking a look at many patients in his cohort. Specifically, they did ultrasound in 181 sarcoidosis patients in his clinic, and they only found pleural effusion in 5 out of those 181 patients. So that's about 2.8%. And out of those 5, after some studies, especially doing something that we call thoracentesis, removing some of the fluid and sending for analyses, only 2 out of those 5 had the pleural effusion from sarcoidosis. So definitely a rare presentation of the disease. Those terms here, exudate and lymphocytic, those are things that we use whenever we do the thoracentesis or remove the fluid. We take a look at some numbers in that fluid analysis, and we classify the fluid in exudate versus transudate, or lymphocytic versus not lymphocytic. And in sarcoidosis, you want to see exudate and lymphocytic, meaning a lot of protein in the fluid and a lot of lymphocytes in that fluid. One specific type of pleural effusion, which is even less common, is this entity that we call chylothorax. This is basically a pleural effusion, again, fluid around the lung, but it's caused specifically by a problem in the lymphatic system. You basically have this fluid, this lymph material from the lymphatic system going into the pleural space, in that space around the lung. This is extremely rare in sarcoidosis. We see this more frequently in other lung diseases, for example, lymphangial leiomyomatosis, but in sarcoidosis, this is extremely rare. In this study here, which was a review of the literature up to 2021, only 16 cases were found with sarcoidosis and this chylothorax. Most of those cases had that chylothorax because the sarcoidosis, the lymphadenopathy, for example, was causing compression of the thoracic duct directly, and this was causing leak of that lymph from the thoracic duct to the pleural space. But in one of those patients, there was direct inflammation from the granulomas in that pleural membrane causing this chylothorax. Again, very rare, but important to know because we have to send specific tests in the pleural fluid called chylomicrons and triglycerides, so 2 different tests that we send. And if patients have chylothorax, the treatment is very different. For example, we have to do a lot of diet modifications to try to improve this chylothorax in patients with this entity. So moving on to the heart, fluid accumulation doesn't happen only around the lungs. So rarely it can affect the heart as well. And this is what we call pericardial effusion. This is also uncommon. You can see in this picture here from one of our patients, this is the heart, and around the heart there is this pericardial effusion, very large amount of fluid around the heart. Our group did a study, a review of the literature to see how frequent we see this in the literature. Again, 27 patients only, so very low number of patients with pericardial effusion in the literature, another rare presentation. Very important to know this for a few reasons. One, about half of those patients also have cardiac sarcoidosis. So not just sarcoidosis causing this fluid around the heart, but sarcoidosis affecting the heart muscle. So if we have that, we have to be more mindful and be more aware of the possibility of cardiac sarcoidosis. The other reason to recognize this is a lot of times this unfortunately doesn't respond to medical therapy alone, just to prednisone, for example, or methotrexate. We need to drain this with a procedure called pericardiocentesis, or sometimes they need a pericardial window to drain this and improve the heart function. But absolutely another rare manifestation of cardiac sarcoidosis. Cardiac sarcoidosis more frequently causes a low strength of the heart, a weak heart, or heart arrhythmias or heart blocks, as you all know. But in this patient, for example, he had a cardiac mass. So this is another rare presentation of sarcoidosis. You can see this darker area here. This is a mass in the patient's right atrium, in her right atrium. Usually when we see a mass like this, we think, unfortunately, of cancer such as sarcoma or lymphoma. But in this case, after the biopsy, this turned out to be sarcoidosis presenting with this rare cardiac mass. And as you can see here in the PET scan, that mass was PET positive, lighting up with the contrast, which usually we see in sarcoidosis. Here's another rare presentation of cardiac sarcoidosis. As I mentioned already, yes, heart failure is a common cause, a common presentation of cardiac sarcoidosis in patients with this disease, but most of the time it causes this weak, dilated heart. In this case, patients can present with a thick heart, thicker than usual. In his picture here, this is an echocardiogram. You can see the septum, or the muscle, the area of the heart that is between the left ventricle and the right ventricle, and it's thicker than usual. It should not be that thick. So this patient had what we call hypertrophic obstructive cardiomyopathy, or HOCM, but caused by sarcoidosis. And she underwent a myectomy, which is a procedure for that disease. And in that myectomy, we were able to see granulomas from sarcoidosis causing this. So we only found out that this was caused by sarcoidosis after the surgery. So very important to know that this hypertrophic obstructive cardiomyopathy can also rarely happen in sarcoidosis. I also debated if I should show this, but I think it's important because sometimes, as you know, with cardiac sarcoidosis, the sarcoidosis is affecting only the heart, no other place in the body. And we call this isolated cardiac sarcoidosis. This is unusual. Cardiac sarcoidosis is unusual already. Only about 5% of patients have significant manifestations from cardiac sarcoidosis. Of course, if you look at MRI studies, for example, the chance of having cardiac involvement is probably higher, but causing a significant disease, only about 5%. Isolated cardiac sarcoidosis, meaning only in the heart, it's a minority of this group. And this is one nice study from Dr. Birdie and his colleagues in Canada that highlighted this. So they looked at 31 patients with cardiac sarcoidosis in their cohort, but after an extensive evaluation, including ophthalmology evaluation, dermatology evaluation, and PET scan, whole body PET scan, only 1 out of those 31 patients with cardiac sarcoidosis had the disease limited to the heart. So this is about 3.2% of patients with cardiac sarcoidosis with isolated disease. Yes, you see some other cohorts, other centers with a bit of a higher prevalence, but I think the important message is it is unusual to have isolated cardiac sarcoidosis. If we have that, we have to look at other entities. We have to be more careful in ruling out, for example, coronary artery disease, which is more common and it can mimic sarcoidosis. We have to rule out genetic cardiomyopathies, which can really mimic cardiac sarcoidosis. So we just have to be mindful of that. This is a picture of one of the patients in their cohort, and you can see here the heart inflammation. But when they did the whole body PET, the patient had bone involvement, the patient had lymph glands in the chest, so other signs of sarcoidosis, not just in the heart. Moving on to musculoskeletal manifestations, it's definitely not a rare manifestation of sarcoidosis, it's common, but I wanted to show this diagram here because it shows, at least in one study from the Mayo Clinic, the most common joints being affected. And I wanted to highlight the ankle. So in this cohort, the ankles were more commonly involved. So if we see patients with no ankle involvement, this is unusual, right? It is how we use this data here. It is unusual not to have ankle involvement in a joint sarcoidosis or sarcoid arthropathy. The other thing that is important is, as you can see, most patients had 2 to 4 joints being affected. If we see only one joint, that's also unusual, right? So we have to keep those things in mind, because anytime that we see patients with joint involvement, which is a very debilitating thing for many patients, we have to be careful. We have to decide, is this joint pain from sarcoidosis or from something else? Muscle involvement, it is less common than joint involvement, and this is one study highlighting this. Only about 0.5 to 2.5% of patients had muscle involvement in this study, 12 patients in 5 years in the Netherlands, and most of those patients presented with proximal weakness and myalgias. So if you're having proximal muscle weakness, especially of the lower extremities, but it can happen in the arm as well, this could be muscle involvement from sarcoidosis, although keep in mind that this is a very rare involvement. The MRI is very helpful in those cases because it can show things that are a little bit more typical and specific for sarcoidosis, such as nodules in the muscles, but sometimes it can show non-specific things such as muscle edema. We just see swelling of the muscles, and this is not specific for sarcoidosis. Whenever we see that, there's at least this study showing that the type of swelling, the type of edema that you see in the heart, in the muscle, makes a difference. If we see a more diffuse swelling, then this is non-specific. You can see that, we can see that in other diseases. But if we see a more linear swelling like we are seeing here, this is more specific to sarcoidosis, to muscle involvement from sarcoidosis. And this has been called the tiger man appearance in some studies. So this linear, all of those white lines here representing this linear swelling of the muscles. Moving on to ocular manifestations, again, a very common manifestation in sarcoidosis, but there are rare types of ocular involvement. And this is probably, out of everything that I'm showing you in this lecture, this is probably the least common one. We've seen one patient here at the clinic with peripheral ulcerative keratitis. We could only find 2 cases in the literature, so extremely, extremely rare, but important to be aware that this can happen as well. Patients can present with tearing, decreased vision, pain, and this is a picture of a test that the ophthalmologist can do. It's called optical coherence tomography, or OCT. And you see this ulcer, or this decrease in the thickness of the cornea in this picture, and this is a sign of this ulcerative keratitis. Again, extremely, extremely rare, very important to rule out other diseases that can cause this, such as other inflammatory diseases like vasculitis or infections. We definitely, of course, need the ophthalmology expertise here to make that call, but important to know that it can be a rare manifestation in patients with sarcoidosis. Hepatic manifestations, again, common, but there are unusual manifestations within that group. This is one of the largest studies including patients with biopsy-proven liver sarcoidosis. 70 patients recently published and showing a few things that we know are common. For example, of course, the non-necrotizing granulomas and some giant cells. Most patients had those in the biopsies. But here's what I wanted to highlight, because we see some of those patients, this is less common, but definitely important to know. So patients can have bile duct abnormalities in hepatic sarcoidosis, and it can get advanced to the point that it looks like another entity called sclerosing cholangitis. So we have to keep that in mind. If we have patients presenting with a lot of bile duct stricture or stenosis, yes, we have to look at other diseases such as primary sclerosing cholangitis, but we have to be aware that rarely that can happen in sarcoidosis as well. Renal manifestation, I think it's a similar story. This is the largest study that I know, including biopsy-proven renal sarcoidosis, 47 patients. And most of those patients, again, had granulomas in the biopsies, right? But the second type of renal involvement was interstitial nephritis, meaning inflammation in the kidneys with no granulomas. So if we don't see granulomas in the kidney biopsy, that could still be sarcoidosis, something important to be aware. And then even less common is to see problems in the glomeruli. So the glomeruli are the tiniest structure in the kidneys, a group of a cluster of capillaries, tiny vessels, very important for the kidney function, and again, rarely affected by sarcoidosis. There are bigger groups of diseases called glomerulonephritis that are different than sarcoidosis, but this study showed that even rarely that structure, the glomerulus, can be affected by sarcoidosis, so we have to keep that in mind. Now, changing gears here to the second part of the talk, when we'll approach now organs that are rarely affected, right? So up until now, we've been talking about organs that are commonly affected, but just going over some rare manifestations. Now we'll focus on organs that are rarely affected by sarcoidosis. And I think one good study to quote here is that one that I had mentioned by Dr. Judson, because he specifically looked at this type of presentation in his cohort. A large cohort of patients with sarcoidosis, more than 1,000 patients over 10 years, and 26 patients, only 2.2%, presented with what they called rare organ manifestation. Again, just as a reminder, those were organs that were not included in that WASOG instrument. So here are some of the organs that they found: esophagus, stomach, testicles, fallopian tube, endometrium, breast, pancreas. So all of those things can rarely be affected by sarcoidosis, and we'll tackle some of those now. Starting with the GI tract, we see, a few patients with really debilitating symptoms from GI involvement. So I think it's important to spend a few slides talking about this. This is an important study by Dr. Boffman and his group, looking at a review including 238 patients with gastrointestinal sarcoidosis, and it can affect really any area of the GI tract. So here is a picture showing the esophageal involvement from sarcoidosis. Sarcoidosis can affect the esophagus in any location and in many different ways. If you look at the right side here, you can see that sarcoidosis can cause mucosal infiltration, meaning granulomatous inflammation directly affecting the mucosa of the esophagus. But it can cause also stricture in the lower end of the esophagus, something that we call achalasia. Rarely this can happen in sarcoidosis as well. And it can cause esophageal involvement by indirect mechanisms, for example, by compression from lymph nodes. So lymph node enlargement, it's very common. It rarely can cause esophageal compression, but in some cases it does. All of those things will cause a lot of dysphagia. So this is the thing to watch for: dysphagia, difficulty swallowing, sensation of food being stuck in the GI tract. All of this can be a manifestation of this rare presentation of sarcoidosis. In that study, they also described the gastric involvement. And you can see here that there are different types of gastric involvement. Diffuse involvement in most patients with granulomatous inflammation diffusely across the gastric mucosa, causing pain, anemia, weight loss. Ulcer, it's also possible in 29% of patients in that study. It can be just one ulcer or multiple ulcers. And very important to know that, because sometimes the presentation is more severe, causing acute pain or acute bleeding from that ulcer. Pyloric involvement is important to know that it happens as well. This is a valve at the end of the esophagus. And again, it can cause pain if sarcoidosis is affecting that area. Again, only in 11% of those patients. And then some of those patients also present with just polyps. So incidental finding of either one or multiple polyps in the stomach. Here's one example of a patient with gastric sarcoidosis. In this specific case, the patient presented with ulcers, and biopsy showed granulomas, proving that this was gastric sarcoidosis. Small bowel and large bowel can also be affected. In that same study, they show that small bowel involvement can cause abdominal pain, diarrhea, and weight loss. In any of those rare manifestations, it's important to highlight this, not only in small bowel involvement, but in any rare manifestation. we have to be more careful to rule out other diseases that more commonly would cause those issues, right? So in small bowel involvement, this is also true. And we have to count with the help of the GI specialist, the gastroenterologist, to make sure that we rule out inflammatory bowel disease, such as Crohn's disease or ulcerative colitis. We also have to be careful and rule out Whipple disease from this bacteria called Tropherema whipplei, which can mimic sarcoidosis as well. It can cause some granulomas in the GI tract or celiac disease even. So all of those things, we need the help of the GI doctor to make sure that, patients don't have that. We have to rule out those issues, and then we can say, okay, this is most likely this rare manifestation of small bowel involvement. Large bowel involvement can also be affected, causing abdominal pain, diarrhea, weight loss, and interesting, it can cause appendicitis as well, right? So there are some case reports of appendicitis being caused by sarcoidosis, and the appendix needs to be removed, and the pathology shows granulomatous inflammation causing the patient's presentation. Here's a case report of pancreatic sarcoidosis. You can see in the pictures first here, the pancreas and the PET scan showing inflammation in the pancreas. It is absolutely a rare manifestation of sarcoidosis. It does not happen often. Most patients present with no symptoms at all, with incidental mass or lesions found in the pancreas. But if they have symptoms, abdominal pain, weight loss, jaundice, vomiting, those can be manifestations of this disease. Very important to, again, do good imaging studies such as PET scan and MRI, get the GI doctor or GI team involved, and almost every time a biopsy is needed to make sure that this is really sarcoidosis and not something else like cancer, for example. Here's another rare presentation. So testicular sarcoidosis, we've seen a few of those cases here at the clinic. This is a study looking at a case report and a literature review, and you can see how rare this is, right? So only 48 cases described in the literature. They described one specific case, a patient with 42 years old with abdominal pain. The abdominal pain was from something else, but the image in the PET scan showed this FTG uptake in the left testicle, and this is the ultrasound also showing a lesion here in the left testicle. Very important to do those imaging studies, but it's very hard to differentiate this from testicular cancer, for example. So most of the time, a biopsy is needed to prove that this is sarcoidosis, again, to make sure that we are not missing any cancer. And you're going to see this theme in many different rare presentations of sarcoidosis, right? Sometimes they can look like cancer, so having a biopsy is important to make sure that we are not dealing with something else. Here's a case of endometrial sarcoidosis published in this study, a 36-year-old woman with metrorrhagia and presenting with endometrial sarcoidosis. You can see here granulomas in the endometrium and in the myometrium, a close-up of those granulomas here. And in this study, they also did a review of the literature, and they found that less than 20 cases in the literature were described to have endometrial sarcoidosis. So absolutely very rare disease. But again, not only in a talk like today, when we're talking about rare manifestations, but in clinical practice, we have to keep those things in mind because those rare things absolutely happen. Breast sarcoidosis is also important to talk about. Only about 1% of women with sarcoidosis will have that. It can be both unilateral or bilateral. Mammogram and ultrasound are still the best studies to look at this. And here are some pictures to show what it looks like. Mammogram shows this irregular or well-defined masses, as you can see here in figures A and B. Ultrasound shows irregular hypoechoic masses, as you can see here in figure C. Biopsy is extremely important. We cannot make the diagnosis here based on imaging alone. We have to make sure that this is not breast cancer. And in this case, this was breast sarcoidosis. Moving on to thyroid, one of the least common organs affected, prevalence 1 to 4.5% in the medical literature, only 71 cases described. It can present with a goiter, with enlargement of the thyroid nodules. It can present with abnormal function of the thyroid, hypothyroidism, hyperthyroidism. So all of those things really can happen. It is important to know, though, that sometimes it's not thyroid sarcoidosis. Sometimes it is just sarcoidosis in other organs, but sarcoidosis is associated with some autoimmune diseases, including autoimmune diseases that can affect the thyroid, such as Graves' disease that can cause hyperthyroidism, or Hashimoto's disease that can cause hypothyroidism. So keep those two things in mind. It can either be rarely granulomas affecting the thyroid directly, which is very rare, or there's also rare association between sarcoidosis and autoimmune diseases in general. Believe it or not, but even parathyroid can be affected by sarcoidosis. This is a case report showing that in a patient with sarcoidosis and hypercalcemia, they suspected parathyroid disease because the PTH was normal. As most of you know, if you have hypercalcemia from sarcoidosis, if it's really the granulomas, the sarcoidosis causing the hypercalcemia, you want to see a normal or a decreased PTH. We don't want to see, sorry, you want to see a suppressed PTH, a decreased PTH. If you see a normal or an increased PTH, we should not think of sarcoidosis. We should focus on the parathyroid. So that's what they did in this case. But believe it or not, the parathyroid biopsy did show granuloma. So this is a rare case of granulomatous inflammation affecting the parathyroid gland. Oral sarcoidosis is also extremely unusual. This is a multi-center study in France showing only 12 patients with biopsy-proven oral sarcoidosis, and many things can happen: nodules, ulcers. It can affect the tongues, the lips, the palate. This is a case affecting the hard palate, for example. So that is absolutely another rare presentation of sarcoidosis. Even teeth can be affected by sarcoidosis, not because of direct dental involvement, but because the structures around the teeth can be affected, such as the maxillary or mandibular bones. So this is a case report and a review of the literature showing 20 cases with maxillary or mandibular sarcoidosis. It's usually localized, but it can mimic this entity called periodontitis, which is a more diffuse process. And here's a case that they included in that publication of a 46-year-old male with sarcoidosis, and he was losing his teeth gradually, and it took years for a biopsy to be done and to realize that this was from a direct involvement of sarcoidosis in those areas around his teeth. To finish, nail sarcoidosis, extremely rare, but this is a case of a patient with chronic painless swelling in both forefingers and nail dystrophy. This was published in the Sarcoidosis Journal recently. And you can see here in this imaging the loss of bone and nail in that fourth finger, and the picture here of what it looks like. So again, rarely nails can be affected by sarcoidosis as well. So with that, I want to finish. I want to leave 15 minutes for questions and answers. But I want to finish with this quote by this once a famous French pulmonologist. And he used to say that if you see 5 cases of sarcoidosis, you know nothing about sarcoidosis. If you see 50 cases of sarcoidosis, you know everything about sarcoidosis. If you see 500 cases, you see nothing about sarcoidosis. So preparing for this lecture really reminded me of this, because you have to always, be humble, be ready to learn new things, and by doing that, treat patients better. And I will finish by thanking you. So this is a picture from the patient volunteer training that happened here at the clinic, led by my colleague, Dr. Harper. You can see Mary here. But I wanted to show this really to thank you, the patients, right? Because we learn from you. The only reason we could do a lecture like this is because we learn from you every single day. When we see you in clinic, when you allow us to share your story with other folks, when you participate in bigger studies, for example, clinical trials, that's how we learn. That's how we move forward. So keep doing this, and thank you all very much.
Thank you so much, Dr. Ribeiro. That was incredible. So interesting, so informational. And the chat has a bunch of people, many people, just thanking you for being able to offer this topic. So I have some questions. Continue to drop your questions in the Q&A. But one of the first is, and you did touch on how sarcoidosis could impact the musculoskeletal system, but this question is specifically asking about how sarcoidosis of the joints can be diagnosed and the types of tests that should be used, as well as the specialist who maybe should do
Yeah.
that diagnosis as well.
Yeah, that's a very challenging situation, Kate, because it is very hard. It is tough to find out on a day-to-day practice if the joint pain is from sarcoidosis or something else. So I think we definitely need a good rheumatologist with expertise in sarcoidosis to rule out other diseases such as rheumatoid arthritis or osteoarthritis that can cause joint pain as well. And then a good sarcoidosis team to look at other organs and see that everything else fits with sarcoidosis. And then, of course, the pattern of joint involvement, like I mentioned, so ankle involvement, small joints of hands, elbows, those are usually joint involvements that we see. Imaging studies, they are helpful. X-rays, for example, sometimes that simple can show significant osteoarthritis. So if we see that, we move away from sarcoidosis and we focus on osteoarthritis management.
Great, thank you. Speaking of imaging, we do have a number of questions in different ways, but asking about when a PET scan should be used and if there's ever a situation where sarcoidosis patients should maybe get an annual full PET imaging of the full body.
Yeah, I think a PET scan should be used in two situations. One, when we don't know if a patient has sarcoidosis, we are still struggling to find an answer. And a lot of times, unfortunately, in those situations, the possibility of cancer comes up or lymphoma comes up. So whenever we are establishing the diagnosis, a PET scan is very helpful. It can show us areas to biopsy. It can show us patterns that are more typical to sarcoidosis versus other diseases. So I think that's one scenario. The other scenario that it's extremely helpful is cardiac sarcoidosis, both to diagnose cardiac sarcoidosis, decide who needs treatment, and to monitor treatment. So that is, for example, the only situation that I recommend doing serial PET scans is when you have cardiac sarcoidosis and you want to see see if the treatment is working. There are some other rare exceptions, but those I think will be the two main groups when I think will be useful.
Great, thank you. And now there were a few questions about diet. So I'm going to kind of combine it all together, but they want to know if you believe that what one eats can affect the disease. So is there a specific type of diet or anti-inflammatory diet that folks should follow?
Mm-hmm.
And then an addendum to that too is, are there any benefits to fasting?
Yeah, so I do believe, Kate, I do believe that diet is important. There are not a lot of studies in sarcoidosis specifically. There's only one small study that I know looking at anti-inflammatory diet in inflammatory conditions. But we know, for example, that those diets are helpful for heart disease, for example, right? So I do think that this group that we say anti-inflammatory diets that can be helpful, maybe not just to like in severe cases, I don't think the diet itself will be enough to control the disease completely, but to help the medications, or maybe in less severe cases, to control the disease without treatment, I think that's probably useful. Good examples of those diets, my favorite one really is the Mediterranean diet. Again, it has been good for the heart for many, many years. So if anything, you are helping your heart health with that. The keto diet is a good example as well. I think the common theme in those diets, and I tell my patients this, is to decrease the amount of red meat and decrease the amount of sugar, of simple stripped carbohydrates that we see in like pasta, flour, bread, all of those good things. But those are, I think, will be the things to kind of try to limit, to try to control inflammation.
Great, thank you. Should a person be concerned about sun exposure when living with sarcoidosis?
Yeah, so not necessarily, not initially. I think in most patients with sarcoidosis, you can keep having the usual sun exposure. Of course, taking the same precaution that everybody does to prevent skin cancer, using sunscreen, using those UV shirts. I think most of the time this applies to most patients with sarcoidosis. There are some patients that, as many of you know, that will develop high calcium, hypercalcemia, and that is hard to control. So if we have those patients with hypercalcemia, refractory hypercalcemia, then we start to take a step farther, and we start to recommend decreasing sun exposure, decrease calcium and vitamin D intake in the diet. But I think for most patients, just the standard precautions is fine.
Okay. So follow up to that is, do vitamin deficiencies impact sarcoidosis? So I think you were kind of touching on that.
Mhm. Yeah, I don't think they impact sarcoidosis directly, but many vitamin deficiencies are important when you are trying to find out, for example, if a neuropathy is from sarcoidosis or from something else, right? So vitamin B12 deficiency can cause neuropathy, can cause anemia. So I think when you're trying to tease that out, knowing if the patient has some type of vitamin deficiency can help.
Okay. And then there was a follow-up question in here about diet, about the fasting component. Is there any benefit to fasting?
Yeah, so not that I know like specifically to sarcoidosis, but for weight loss in general, and keep in mind I'm not a weight loss specialist, not an endocrinologist, but what I hear from them is that different things work for different patients, right? So I think the way to go about those diet changes, specifically when it relates to weight loss, having a conversation with your doctor, either primary care physician or endocrinologist, and trying to find which one is the best for you. That's the way to go. And yes, for some people, the prolonged fasting may help, but it may not be true for other folks.
Okay. A question came in about having some problems with their eye due to sarcoidosis. So there's some double images, and they
Mhm.
want to know if it could potentially be corrected with a type of surgery.
So yes, so those things can happen with sarcoidosis. They are common, actually. That's why I didn't address them specifically today. But ocular sarcoidosis is common. Neurosarcoidosis affecting the cranial nerves and then causing some double vision. That's one of the most common manifestations of neurosarcoidosis. Those things can absolutely happen. I think correction for that, if it's caused by sarcoidosis, usually we try to fix that with medications first, right? Ideally, we want to find those things early while it's still a lot of inflammation and not a scar tissue. And we can treat with the usual medications, methotrexate, infliximab, and try to improve the symptoms with medication and not surgery.
Great. A question about neurosarcoidosis and if they should be getting lumbar punctures or spinal taps on a regular basis or annually.
That's a great question, actually, because yes, I think for most patients with neurosarcoidosis, you should get lumbar puncture initially, especially if you have a rare type of neurosarcoidosis, which is the isolated neurosarcoidosis. Neurosarcoidosis affected only the nerve system, like in no other place, no lung sarcoidosis, nothing else. Those cases, it's very tough to diagnose, similarly to any other isolated presentation, such as isolated cardiac. So in those patients, a lumbar puncture, it's almost mandatory because you have to rule out infection. You can't distinguish neurosarcoidosis from infectious meningitis, for example, just based on imaging. And at least in the initial visit, you'll be mandatory. Serial lumbar puncture, I would say most patients don't need. I think we rely more on physical exam and serial imaging, like serial MRI. We do that more frequently, but in some cases it's necessary. If there's a situation that we still don't know based on clinical evaluation and imaging evaluation, if the sarcoidosis is still active, I think doing a repeat lumbar puncture will be helpful.
Question about if there's any research that you might know of or any thoughts on how the GLP-1s, those medications, could assist in decreasing inflammation.
Yeah, so not that I know of, specifically in sarcoidosis, no big studies, no clinical trials that I know looking into this. I know that there are some groups doing smaller studies, retrospective reviews to see what is the impact of those medications in sarcoidosis. So this is ongoing, which is usually the first step before we do bigger studies. But those medications, they are helping so many other diseases that I honestly wouldn't be surprised if at some point we start seeing studies looking at inflammatory diseases and then specifically in sarcoidosis at some point, but nothing big at the moment that I know of.
More people just saying how wonderful this is, how excited they are that it will be.
So
Could
Dr.
you just take
Ribeiro, while you were looking for Kate, one thing that I've seen pretty consistent in the chat that I thought maybe you could address are environmental issues.
Mm-hmm.
It's talked a lot about with sarcoidosis and the environment, and is that an environmental trigger contributing to that? And specifically with these rare manifestations that you highlighted today, what are your thoughts, or what does the research indicate about that?
Yeah, no, I agree, Mary. I think this is extremely important. We were just in the WASOG meeting in Canada just a few months ago, and there was a whole session only for environmental exposures and the risk of that, triggering or causing sarcoidosis. One of my colleagues, Maeve McMurdo, that's her main area of research, looking at those environmental exposures and associations with sarcoid. So I think there are many potential culprits. There are things that I think are more well established. For example, smoke exposure from firefighters. This has been very well established as something that increases the risk of sarcoidosis. I think the pesticide story is also quite, convincing. And as you said, it can even trigger like specific manifestations like cardiac sarcoidosis. So I think the field is definitely moving in that direction of more and more trying to identify those triggers, and then if we do that, hopefully be able to prevent. But I do think, and this is my feeling, that we want to be able to find just like one or two. I think that there are many different triggers that can trigger sarcoidosis in different patients based on their genetic background.
Thank you.
Thank you, Mary. I see another question in asking about lymph node involvement, and is it common to have lymph nodes in your groin affected by sarcoidosis?
Yes, so lymph node involvement, it's one of the most common, and you can have lymph node anywhere in the body. The most common site is the chest, right? But you can absolutely see extra pulmonary lymph node involvement. I think the rare thing about the lymph node involvement is, depending on the location, it can compress one organ and cause an unusual manifestation, like the esophageal sarcoidosis, for example. It's common to have lymph node involvement in the chest, but to have it to a point that it's compressing the esophagus and causing symptoms, that is the unusual part of it.
Thank you. And I think we have time for one more question. And it's asking about seeing sarcoidosis in children, and specifically asking about neurosarcoidosis in children.
Yeah, so it can happen. There's actually a genetic condition called Blau syndrome, and there's another condition that it's called early onset sarcoidosis, which is quite similar. Sometimes they're grouped together, but those are types of sarcoidosis that tend to happen earlier in life. And usually, I think the teaching point is, if you see kids with sarcoidosis, you should definitely think of those genetic entities, especially the Blau syndrome.
I know we're up on time. I just want to check between. Oh, if you don't mind, one last question about sarcoidosis
Absolutely.
within the abdomen.
Mm-hmm. Yeah, so it does happen, right? But it depends really on what organ we are referring to. So you can have common manifestations in the abdomen, such as spleen involvement, hepatic involvement, those are common. Or you can have less common manifestations, such as the GI involvement that I mentioned. or the abdominal wall sometimes can be affected rarely. Those are more rare manifestations, but yes, absolutely, the abdomen can be affected.
Thank you so much. That was wonderful, Dr. Ribeiro.
My pleasure,
I
Kate and Mary. No, it's a real pleasure, and I hope this was useful, right? So it's always a
oh,
pleasure to chat with all of you and share again what we learned from patients, right? From the ones that are joining this today, and grow as a group, as a community, and it's always a pleasure.
Well, Dr. Ribeiro,
thank
I just want to say, as Kate mentioned earlier, the chat was on fire with appreciation and thank yous to you, as well as many, many questions and patients sharing information with other patients. So greatly appreciate all that. Thank you for your valuable time and for sharing such an extraordinary presentation for the sarcoidosis community. And we also know that you do a lot of presentations to the medical community, and yet you took the time to translate very complex information into layman's terms for those of us that do not have medical training, so that we can all understand these rare manifestations. And we very much appreciate that. We are honored again to have Cleveland Clinic as a founding member of the Global Sarcoidosis Clinic Alliance, working so closely together on advancing research, support, education, and awareness. I also want to thank our audience who joined this extraordinary webinar today. Your very thoughtful questions led to additional understanding and information that Dr. Ribeiro could handle for all of us. And anyway, just appreciate all the patients sharing information. As Dr. Ribeiro said, we learn so much from you on an ongoing basis. Again, this webinar has been recorded and will be posted on FSR's website. And so grateful to everybody today. Thank you again, Dr. Ribeiro.
Thank you
thank
all
you. We
again,
will.
and have an amazing day.
Okay,
Thank you.
bye-bye.
Bye bye.